transverse arch compared to the patent ductus arteriosus here, the VSD, and the reconstructed 3D view of the aortic arch. Just to finalize, just want to make a point about whenever you imaging the heart, you have to also make sure that you image other parts of the baby, because there may be something else going on that you don't appreciate. And the same is true if you image brain or body, you should also look at the heart. So this is a baby that was known to have Epstein anomaly, and they were interested in looking at the lung volumes for this baby, so we did an MRI. So these are the images with the Doppler device showing the findings of Epstein anomaly. And this was not any different than what was known by echocardiogram. But what happened in this baby is that when we looked at the baby's brain, so these are super resolution images of the brain in the 3 planes. And here we have the cystic lesion adjacent to the periventricular white matter. So suggestive of a periventricular locomalacia. And then when we looked at that with the gradient echo EPI sequences, we see that there are lots of microbleeds, in the central semivalley bilaterally periventricular white matter. And this baby turned out to have, in addition to the Epstein anomaly, he had periventricular locomalacia. And that changed the counseling for this patient. So in conclusion, is really possible to obtain high-quality images of the fetal heart by fetal cardiac MRI gated by an MRI-compatible Doppler device. And you're going to see in the next presentation, and you've seen from the prior seminar from Germany, lots of very good images, even at 3 Tesla, better than the ones that I've shown here. It's essential to get localizers before placing the device so you can understand where the fetal heart is. And then you really must work closely with the patient, family, technologists to motivate and overcome the initial difficulties to try to get a good signal from the Doppler device. And I'm going to stop the presentation here, and we're going to have a session for questions and answers later.
Thank you, Luis, for your presentation. Very valuable. So we just directly hand over to Shu. And discussion is later. And you can still post your questions in the chat. Great.
Sure, thanks, Heider. I'm sharing my screen, and I hope everyone can already see it.
Yeah, we can see it perfectly fine, Shu.
Excellent. Good morning, good afternoon, and good evening, depending on where you are. This is Shu Zhang speaking from Philips, today from Germany. And I'm happy to share some of the learnings on this topic. So after going through the clinical applications and impact by using the ultrasound gating device from Luis, I think it's actually a good time to step back now and look from the technical angle to see if and how we can further improve the fetal cardiac exam. I'm going to focus on some of the technical points, deep dive in some of them before we look at the big pictures again. And finally, I hope I can shed some light on the future perspectives. So very similar to cardiac MRI in adults and children, the fetal cardiovascular MRI consists also several scan techniques. You usually start with a survey scan, which is orthogonal to 3 planes according to the maternal reference. And then you can switch to a dedicated fetal survey using dark blood TSE, which then consists of 3 orthogonal planes with reference to the fetus. The balanced TFE or SSFP can also be used for multi-shot morphology or a single-shot thick slices dynamic scans of the fetus. These 2 are optional, but they may provide you actually with some additional information. And of course, today we are going to focus on cine because that is the advantage where we can benefit from combining the ultrasound gating device. And of course, you can also do a phase contrast flow measurement. We won't be able to cover it today, but if you are interested, I think we're happy to take it offline or in the Q&A session. So you have seen already examples from Luis without using the gating device, but simulated ECG signal. A more conventional way was actually to simply push the technique to its limit. For example, here by using the single shot balanced sequence and just run as fast as you can. And of course, in this case, it's quite a big compromise between temporal and the spatial resolution. And that is where the SmartSync ultrasound gating device come into play. And by properly setting up the scan sequence and also managing the exam, this is the quality we can expect using the clinical scan protocols. And this is one example from 1.5 Tesla. Before moving to the key imaging parameters in details, I do want to mention that so far there is no consensus fetal cardiac MRI exam, but there are some guidelines from adults and the children. If we take a look at them, it is a quite big range actually, at least for spatial resolution. In terms of temporal resolution, it's really recommended to have a acquisition time shorter than 45 milliseconds in order to capture the wall motion of the heart between every actually acquired cardiac phases. Some guidelines also recommend only have actually reconstructed cardiac phase. I think we can do better there because these two parameters are actually independent. But you will find a way on the scanner to control them, both of them, depending on how the vendors implement them. And here is a summary of the key parameters that I put together. We know that the pixel size and slice thickness determines the spatial resolution. And for balanced sequence, we recommend to use shortest values for both TR and TE, so that we can reduce the susceptibility artifacts. In addition, there is a push that we can use, and that is to use the maximal bandwidth at the same time minimal water-fed chemical shift. The theoretical water-fed chemical shift is 3.4 or 3.5 ppm. And the actual number actually is determined by the total receiver bandwidth and matrix size. So namely, the number of pixels in the frequency direction. I won't deep dive there, but I have put the equations here on top right, so you can take a look. My point is, by setting up the highest bandwidth and the minimal water-fed shift, this will give you an additional push to reduce the TR and TE on the scanner. And together with the TFE factor, TRTE will determine the temporal resolution. As you can see here, the so-called TFE duration or echo trend length directly corresponds to the temporal resolution. As I mentioned, the temporal resolution and reconstructed cardiac phases are two independent parameters, but they are interlinked. However, depending on the vendor implementation, there is actually easier way to control them. I have some slides to walk you through a few practical examples. And finally, the spatial resolution, number of phase encoding lines, temporal resolution, and acceleration factor will together determine the scan time. Usually we restricted it to be below 15 seconds so that we can actually do a breast hold scan for the mother. And here are some screenshots, examples from the Philips systems so that you know where to find these key parameters on the scanner. For example, from the geometry tag, the contrast tag, and the motion tag, as well as the corresponding values of the actual parameters on the so-called info page. I won't go to details for that. The video is recorded and you can take a look afterwards. And instead, I would like to focus on the temporal resolution because the same principle can be implemented differently on different vendor systems. On Philips platform, as I mentioned, you can find this information in the info page by looking to this parameter, which is called TFE acquisition duration. And here the temporal resolution is 24.5 milliseconds. And some of the other vendor system it might be different. And here's one example from Siemens. And here it is actually shown directly in as TR value. Although it is not physically entirely correct because it does not correspond to the time interval between every excitation pulse. However, as user, you do find this value on the user interface. And here in the example, it is 36.7 milliseconds. And here I would also like to mention that if we take guideline recommendations from adults and children, we can, and then plus the typical heart rate range from the fetuses, we can actually convert or derive more or less the desired temporal resolution for fetal cardiac MRI, which ends up with a 27 millisecond roughly. It's not a must, but it's a rough estimate, which we also actually provide now in our reference protocols. Now let's take a look together how we can modify the temporal resolution, because that is the biggest advantage by using the ultrasound gating device with your routine clinical sequence. And let's take Philips platform as an example. The first option would be to increase directly the reconstructed heart rate, heart phases. Here I have increased the number from 25 to 50, and that means for the same R interval, we will need shorter TFE acquisition duration, basically higher temporal resolution. And of course, the scan time is also prolonged, in this case, doubled. The second option would be to change the acquired heart phases, which is defined in percentage for a range between 50 to 100%. The higher the percentage number, the less the data are shared between the adjacent cardiac phases, which means better temporal fidelity and higher temporal resolution. In this example, I have increased the percentage from 70% to 100%. So the temporal resolution is improved and the scan time is also prolonged, as you can see here. And here I'm showing you these two options as two independent approaches. But in the practice, these two are actually combined together. And there is a very good reason behind that. And that is most of the post-processing software, they only show the number of reconstructed cardiac phases. And the number of acquired cardiac phases is no longer known or even helpful in this case. So in this way, the user can directly define the reconstructed cardiac phase. At the same time, we can also have a control of the temporal resolution. So this is a very important concept here. Of course, the third option is to have the number of heart phases equal max instead of default user-defined. To let the hardware, to let the software calculate the number of reconstructed heart phases automatically, you can change the acquired phase intervals directly to let software know your desired temporal resolution. And here it's 18. And the software will calculate the most matched phase interval. And that is the actual temporal resolution depending on the TR and also the TFE factors, so number of case-based lines. In a very similar way, depending on heart phase percentage, as I explained before, it will determines the number of reconstructed heart phases. It will be calculated and displayed on the info page. The advantage here is the user can directly define the temporal resolution in milliseconds, while at the same time keeping an eye on the reconstructed number of phases. In addition, for hardcore physicists, I know some of you are listening here in the audience, for you, what happens exactly in acquisition is most important. In other words, how many reconstructed cardiac phases at the end does not matter much. You probably have your own way to look into some of the research options for offline reconstruction. So here you go. In the contrast tag, you can change the short mode, TFE short mode from default to multi-shot. In this case, the TFE factor will become visible, and you can directly change this number to determine or to decide the temporal resolution. And here I have increased it from 6 to 11, which means 11 case-based lines will be acquired. And in this case, the temporal resolution is getting longer or poorer, but still I was able to control it below 45 milliseconds. And the number of acquired hard faces will be at the same time also determined. And as I mentioned, the hard face percentage is from 50% to 100%, which means the resulting reconstructed hard face will be from 8 to 16. So the advantage here is the user can sort of also directly determine the temporal resolution via number of case-based lines per hard face. It's very good for research option, but in the clinical routine, sometimes you may run into conflicts on the user interface. So for clinical users, I would recommend the first to order third options. At this stage, if you feel a little bit confused and even puzzled about what options to use, no worries and don't panic. What I'm going to show you in the next slide, I promise you that will simplify everything. If you already have experience in cardiovascular MRI in general, even in adults or in children, then the recommendation is to start with your own institutional scan protocols or exam cards, because you have the clinical knowledge and you have the basic technical know-how, and you are familiar with your scanners. You can do troubleshooting along the way when you convert your protocol and enter the fetal cardiac exam regime. However, if you don't have the experience so far in cardiovascular MRI in general, the recommendation is to start with the vendor provided or recommended scan protocols, either for adults or for fetuses. On Philips platform, we do provide dedicated scan protocols for fetal cardiovascular MRI exam using the ultrasound device. You can find this field strength article online, and also the exam card are attached. You can download them and plug and play on your scanners. There is now even an updated version for 3 Tesla. Feel free to contact either the fellows from North Medical or from us to try it. So this is how it looks like. Basically, it's an a la carte collection of the sequences based on the user best practice that you may find useful for the fetal cardiac MR. And it's exactly the same sequences and techniques that I have shown before. And here for the cine scan, the default setting contains 3 slices, and you can easily modify it to single slice or even more slices to cover the entire stack. And here are some more examples. And this is the survey scan, which, as I mentioned, containing 3 orthogonal planes to the mother. And you see the crosstalk here in the slices. And this is what I call the fetal survey, containing 3 single slides orthogonal to each other with reference to the fetus. The advantage here is you can then prescribe your multi-slice planning or even cine directly, and you can see where you are scanning exactly in which direction. And the beauty is, of course, the location of the slices will show up also in the other 3 directions. So you won't get lost in the anatomy or translation of the coordinations. Many of us are motivated to move to 3 Tesla to gain a high signal to noise ratio. Yes, theoretically, SNR is in direct proportion to field strength. And indeed, a direct benefit here is relatively higher spatial resolution, as you can see on 3 Tesla comparing to 1.5 Tesla. And for TR and TE, same story, comparing to 1.5, shortest value should be used. The flip angle, however, is compromise. because we have limitation from SAR. And the value of 60 to 65 degree is what we can recommend to for the optimization of the contrast between myocardium and blood. And then the rest of the parameters are almost irrelevant to the field strength. In principle, higher acceleration factor could be used, and that's also what we have seen in the other anatomies. But for fetal heart, so far, most of the time, we are still using the same acceleration factors. But I will show you one example at the end of my talk where high acceleration factor can bring us a big change. In addition, the contrast of the flow, basically the flow to noise ratio at 3 Tesla, will be much better due to longer T1 relaxation time. So in case you are particularly interested in measuring the blood flow, and this could be one good reason moving to 3 Tesla. You have already seen many clinical examples, nice examples from Luis, so I'm not gonna show you more here. If you're interested, you can also find them on the internet by looking at the Philips MR body map or the field strength article magazine that I mentioned, or even from the previous NOS Medical webinar sessions. And here I do want to touch upon some of the technical issues specifically on 3 Tesla. The first one is the B0 inhomogeneity. Very often we have bending artifacts like shown here, which very well correspond to the magnetic field inhomogeneity. And basically that is doubled on 3 Tesla comparing to 1.5 Tesla. And sometimes it could be even worse. It show up in the middle of the field of view, particularly for balanced sequences due to phase cancellation. And what you can do is to have a targeted volume shimming to improve the local field homogeneity. I don't have a problem if you position your shimming box like this, but if you still suffer from bending artifacts or B0 inhomogeneity, a better way could be to have a smaller shimming box targeting at the heart of the fetus. Another way is actually because the fetus may move around a little bit, you can actually position the box posterior to the fetus in the mother back area. We have general good feedback from people who are scanning fetus in general. If you are interested in the fetal heart, why not also have a try? And that.
Sure, this is Nadia. Sorry to interrupt. For the sake of time, I just want to give you the reminder. You have 1.5 more minutes. It would be nice if you can come to an end.
Yes, I think we should also touch upon the B0, B1 inhomogeneity, and then I will come to the conclusion part, if that is okay for you.
That's amazing. Thanks.
Another well-known challenge is, of course, is B1 inhomogeneity on 3 Tesla. In this case, the adaptive RF shimming with multi-transmit can help. However, it is important to keep your SAR operated at the normal mode, restricted to 2 watts per kilogram. I'm approaching to the end of my presentation, and here are also some non-technical learnings that I'd like to share with you, which are equally important, if not more, to master the technical challenges. And first of all, take your time to go through the protocols before your exam. This will be particularly helpful if you don't perform fetal cardiac MRI every day. People tend to forget things, same thing for me as well. And this is also what I learned. We already know from Luis, it's a teamwork, and we know how important the stakeholder management is for a project. So get hold of your technologist or radiographer and look at the protocols together. And second, build your imaging strategy based on all the information you can have, particularly how you would like to start, when to end. And one important tip is actually go to the most important scans as soon as possible. Yeah, it will take some time at the beginning, but once the more you scan, the faster you would be. Last but not least, make sure that the mother feels comfortable lying on the patient table. This will reduce anxiety and also reduce the motions. This is a dancing baby movie I borrowed from Nick and Luis. I think that brings us to the remaining challenges. We all know we already have a very simple but a powerful tool using ultrasound device gating to tackle the fetal cardiac motion, but we still have, we need to manage the other challenges. There are some fantastic tools there, but they are mostly in research. And this is one example by using the fast scan, combining smart sync and also the AI supported reconstruction. So here we can leverage the signal to noise ratio and also go faster. I'm over time, so I'm not going to talk too much more. But by showing this swimming dolphin, I think you get the point. We can't tie up the features, but we certainly need to find good ways to tackle all the challenges, and I'm sure we are moving towards good directions. Thank you for your attention.
Thank you very much. Sure, also Louis again as well. We jump directly to the discussion part because yeah, we only have 18 minutes left. So there was one question for you, Louis, and there was someone asking, you mentioned that there are new exam cards and new Cartesian sequences. Is this something new from Philips? Probably it was maybe answered during Shu's talk, but I would like to mention that again.
Yeah, those are the cards that you can download from the Philips website. I mean, like we said, we begin with our own sequences, and you know, we're actually working to optimize them and moving to 3T and so on. So what I showed was like when we tried to implement the cart that was downloaded. When we use maternal breath hold, that's when we got the best image quality with that particular cart. When we run our own sequences, you know, with 6 millimeter, 4 millimeters, and -2 overlap, or actually 6 -2, it's pretty forgiving, but the resolution is not as good as if you use a higher spatial resolution and try to decrease the motion artifacts from whatever sources there is. In this case, the maternal breathing.
Okay, we have another question, which is also for Louise. Is there a clinical relevance to detecting BAV in the fetus, not considering concomitant coarctation?
BAV for meaning like AV blocks in the fetus using MRI.
I have to admit, I don't know.
That was asked by Pim.
Well,
maybe Pim, you can.
Bicuspid valve is the answer.
Oh, a bicuspid valve, yeah. Well, we never really looked at the bicuspid valve by fetal cardiac MR. I know that one of our fetuses actually had a bicuspid aortic valve, but we didn't see. I think you need to have higher spatial resolution to look into that. So I think if you have echo, is probably the best way right now. Perhaps you know, and I think Alex Barker can either chime in right now or when he gives his webinar with 4D flow. That may be a situation where you would detect the stenosis if you couldn't see by echo, right? But I think you're going to have to use some type of dynamic sequence to do that, like a flow.
All right. Then there's one question for you, Shu. It came up when you did present the key imaging parameter for the CNE. And the question is, how do you reach these high flip angles without reaching the SAR limitations?
60 to 65 degree, that is actually also sometimes we use in the pediatric and adult cases. The calculation of SAR is actually very conservative on Philips scanners. I don't think we will reach SAR, depending on actually the frequency, how faster you scan and how long you scan. But most of the time we get around with it.
Then there was a comment, maybe we can just read it out and maybe it's room for discussion. Even on the best resolution fetal echo, we cannot definitely call a BAV in a valve that works well. Anybody wants to comment on that?
I think there's a tough question. I think it's going to be, even if you're thinking that you can see the valve with fetal cardiac MR as with the resolution that I use, I don't think I'm able to see. I think maybe, like I said, with 4D flow, or even the image that Shua showed later using AI and 3 Tesla, with higher spatial resolution, maybe. But I'm not confident that at least with what we are doing right now, that we can see that.
Agreed.
Thank you.
Yeah.
There was a comment from Alex. I just read it out to answer Louis' comment on BAV. We have yet to see a clear BAV on MRI, even with knowledge a priori from echo. Which is good.
And really, Alex is the one that has probably the largest experience in the world with 4D flow, so that should answer the question, at least from what we know now.
All right, and then Pim was commenting again. My question was also if it even would make sense, the synodic valve was a good point. And maybe we can now remind you to the poll again. We wanted to share these results with you, but it just makes sense as everybody really participating in the poll. So it only takes 1 minute. There might be time to participate in it. Okay. Are there any further questions? Please paste them into the chat.
I've seen a question regarding the shimming settings on the Philips systems. I've answered that in the meantime, but I can also repeat it so the audience can know. That's from Sean. We typically position mother on her side, registered as decupitors. Adaptive RF shim not supported at 3T on the scanner. Yes, as far as I know, this limitation has been lifted, at least for software release 5.8. I'm actually not sure about 5.9. This is a very intermediate software version, but do reach out if you still have this limitation on your scanner.
Okay, it's also not possible at 5.9.
Okay. I will make a note and
yeah, maybe that's a good thing for, yeah, you will get connected. That's amazing.
yeah, we can take it
that makes
offline.
sense.
Definitely.
Great.
Yeah.
Yeah. Amazing. Okay. We don't have any more questions, right, Heide?
Yes.
No more questions, correct?
No,
Okay.
we have no more questions.
Okay, so there is an additional question. For centers wishing to start imaging, what were the biggest struggles, and did you work with your vendors mostly to adjust settings? That's for you, Louise, maybe.
I think the biggest struggle that we have is really like when you go, for example, to use a Doppler device. I think the biggest hurdle in the beginning is, and even with some patients, is to really kind of like position the device and get a good signal in the heart, and that signal holds without the baby moving too much. So I think that's the first portion of the learning curve. And I think what Shu said, we basically went from scanning babies with that external ECG device, and we just kept using the same sequences with the Doppler device. And and then we've been working at this for like almost 2 years now. And the struggles are, if you're imaging other parts of the baby, you're going to have to allocate time for that. So we tend to scan our patients like very early in the morning so we can use an extra half an hour for the heart after consenting and so on. So that is a hurdle. And now the next one, it will be like, how to improve the image quality from what we have now. And if we want to start using 3T and so on. So it's in my opinion, it's a long process. And you're gonna have to have people trained and they're comfortable with doing these images and so on. I don't know if I answered the question.
I would think so, yes. Laura, if you are not happy, you can post it in the chat. Okay.
We had one question during the last webinar. I just want to mention it again because maybe you have experiences with that, Chu or Louis, with twins. Any experience with twins? Are there any technical issues you need to take care of when you want to measure twins?
Well, trying to image twins or babies with polyhydramnios, babies that are moving too much is always going to be a challenge. I think you can image twins, but it's just like going from 1.5 to 3 Tesla, you have more artifacts. Going from singletons to twins, you're taking your chances. You may be able to do it. We haven't done twins, I think, with the Doppler device.
Yeah. Okay.
No, I'm also gonna say I haven't seen cases like that, but I'm a scientist, so I think this will be actually very interesting. Maybe something we can work together with not medical as well to see how the signal can be captured, and how far we can separate them as well to have a clean
Would
sensation of
indeed
the
be a
signal.
very interesting and exciting thing to do. I agree.
If one is awake, the other is going to be awake too, right? I mean, you start kicking the other guy.
Could be.
You need to put both of them to sleep at the same time.
Yeah.
Yeah. And Pim was just answering, you need 2 devices. That's, of course, also a good solution.
Yeah, probably even more. Exactly.
All right. One more question that always comes up again. Do you use black blood or white blood sequences for planning? What is best and why?
I think we use bright blood for planning. We just use the BTFE sequences if they're not like as long as you can use the T2s as well. But I think, and I'm just looking at everybody here. Most of the time we use the BTFEs too. Yeah, we run an axial BTFE, maybe axial and coronal, and then we plan. And we tend to do, and we really focus our scans on axial planes, from abdomen to the mediastinum. And if we have time, we add other planes, but not often we have, all the time. And I think others have, I think the doctors in Germany that presented before also tend to scan on the axial plane and then prescribe planes if possible.
Right. From technical point of view, they have both advantages, and that's why in the reference protocol, we also provide both the single shot TSE with dark blood and then the balance sequence with bright blood. Because what we learn from the general fetal scan, and people tend to use, or people are used actually to dark blood multi-slice, and this works very well on 1.5 and also 3 Tesla. And if you have experience, you can simply adapt that for your planning as well. Otherwise, the single shot BTFE with bright blood, of course, that you can also get additional morphology information from that.
Okay. Then we have one last question. Do you have any recommendations for post-processing methods?
For what? For what purpose? For calculate. Yeah, but for what purpose? Post processing of what information? Volume or
flow, for example. Any recommendations, ideas? How we can also move further there from where we are right now.
Maybe I can comment first, and Luis, you can see what you can suggest. From my point of view, I think if you are using the conventional clinical imaging sequences, then you can start with the vendor's software. Usually they are good enough to process the flow information and the sequences on the scanner and also on the workstations. For offline post-processing, there are plenty of tools. There are CVI42, Arters, Pi Medical. I think you can just pick up any for the flow information. Depending on your preference, there are some advantages and disadvantages.
Yeah, we have not used the 4D flow here, so for me it's hard to comment on that.
Okay. We have one, now it's the final question, and then we need to summarize and close this very exciting session. The question is functional assessment, quantitative analysis. Is it possible?
Does it refer to the quantitative volumetric analysis or the quantitative parametric information like T1, T2, T2 star? I don't know, but I think similar to the conventional MR scans, the functional quantitative volumetric analysis could be interesting. But so far, what I have learned from my collaborators, they are actually more interested in the morphology. I think that's the first step if we know more about that. And certainly, I think the volumetric information will be helpful in terms of monitoring, diagnosis, and comparing even with ultrasound.
Agreed.
Okay. Cool.
All right.
Yeah, I think we need to wrap up this session.
And coming to an end, we would like to share one last time our screen and remind you to also our next session. We hope to see you there at the third session. It will be on March 15th. And then we have the topic about implementing fetal CMR as a diagnostic tool. So there we will move over to a more clinical application. And there we have 4 experts invited. It's going to be David Lloyd, Alec Henstrom from Lund, Eleanor Suchard from Rady, and Lorna Brown from University of Colorado. And yes, we are happy to see you all and also happy about feedback.
Yeah, if there's any topics you were particularly interested in, or if there's any questions we couldn't answer in this session, feel free to post them in the chat. We will stay in this session to to collect them, or you can also send an email to my colleague Heide. We post her email address in a second. And just the reminder, this is a session of a series of 6 webinars. And yeah, we hope to see you at the next one. Thank you for the interactive participation. Thank you, Shuo. Thank you, Louise. It was a great session. And yeah, see you soon.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you, everybody. Bye-bye.